Welcome to Behind the Blue Lines, a special segment of Unplanned and Untold, where we revisit some of our most compelling interviews to provide a space for reflection and education while uncovering the complexities that surround an unplanned pregnancy. Welcome back to another episode of Unplanned and Untold. I'm your host, Caitlin Willing, and today we are thrilled to have an exceptional guest who brings a wealth of knowledge and expertise to our show. With 17 years of experience as a practicing physician in obstetrics and gynecology, her expertise and compassionate approach have made her a trusted and respected figure in her field. Throughout her distinguished career, she has not only delivered countless babies, but has also guided women through complex health issues from routine checkups to intricate medical procedures. In this episode, we're going to dive deep into the world of obstetrics and gynecology. We'll discuss the latest advancements, debunk common myths, and answer some of the most frequently asked questions from our listeners. Without further ado, I would love to welcome my dear friend, Dr. Kerri Hensarling, to the podcast. Welcome.
Yay. Thanks so much, Caitlin. I'm so
Oh,
excited.
I am so excited. I've been looking forward to this interview for a long
I
time
know.
now.
Me as well.
Okay, so we're going to dive right in. We
Yeah,
had
let's do.
so many questions. As you can imagine, our audience are primarily women,
Sure.
some who of which have had unplanned pregnancies, and some who really just listen for the tea of the stories that we
Sure.
get to talk about. So, can we start off by, going through what is obstetrics and how is it different from gynecology? Because I know when I was younger, I always confused OB and OBGYN. And so I feel like we need to kind of debunk a lot of what is the difference between the two.
Sure. So obstetrics is just the care of all things related to pregnancy. And so an obstetrician may take care of patients trying to get pregnant or pre-pregnancy, and then obviously pregnant patients up until labor, through the labor process, and then postpartum. So
Okay.
a gynecologist basically takes care of everything else related to women's reproductive health outside of pregnancy concerns. So
Okay.
if someone is just doing gynecology and doesn't practice obstetrics, they aren't doing deliveries, they don't take care of pregnant patients. I actually am still doing both. And so
Okay.
I get to dabble with a little bit of all of it, which is great.
Wow. So what made you want to go into obstetrics?
Well, I think the question for me, in order to answer it, I have to say why I wanted to do obstetrics and gynecology, because I really do like the diversity. I like the fact that from one day to the next, I may be doing something totally different. I may be in the operating room all day doing gynecological cases, and the next day I may be doing deliveries, and then I may have a day in the office where I'm seeing someone whose baby I delivered 10, 15 years ago, or seeing patients that are currently pregnant, or meeting new patients and just seeing routine patients or dealing with gynecological issues. And so there
Wow.
really is a lot of diversity, which very early on I enjoyed.
Absolutely. So you kind of seen some women full circle from
Yes.
before they're pregnant, then they're pregnant, and then
Yeah, I
after.
love the continuity. The continuity is
Wow.
fantastic. It really, yeah, I'm not quite yet ready to like deliver some grandparents. I'd like to pretend like I'm not old enough, but it won't be long. It won't be long
Oh,
because I mean,
no.
I have, especially if you look back to where I was in residency. I mean, I've been in private practice for 17 years, but then I was in
Wow.
residency for 4 years. Um, it's amazing that clearly I must have started residency at the age of 16. Um, but you get to go, like full circle. You get to be part of these patients' families. Um, yeah, so I'll have patients and then deliver their kids, and there will be patients, I'm sure, that I've delivered their grandkids. It's truly amazing.
Wow, that is really cool. I find it hysterical the first time my son put the pieces together that you
Yes.
delivered him, because for our
Yes.
listeners who don't know, we have boys the same age,
Yes.
and they finally put the pieces together somewhere along the lines that, oh my
Yes.
gosh, this is the same person who delivered me.
Oh, yes. No, my kids, I think sometimes they think it's funny, and then sometimes they think it's because I mean, I have all boys, and so, they go back and forth from thinking it's odd to funny to, that I've delivered a lot of their friends,
Yes,
and then they get to that age where they kind of understand more of what that entails.
exactly.
Um, yeah, which brings, a whole 'nother set of questions.
Truly. I mean, I remember having a conversation with you about your boys learning just the terms, the medical
Yes.
terminology for the body, for the uterus. I mean, at such a young age.
Yes. Which, I am a massive proponent of using real words for so many reasons.
Yes.
Um, but then even my children are hilarious. And when they were younger, the ways that they would misuse words and sometimes shock people. But
Yeah.
I can remember being at the vet with one of our female dogs and one of my boys saying, "Why do we have to take out her uvula?"
Are
And I
you?
was like, okay, not exactly.
Yeah.
You
Yeah.
tried, and as a
Yeah.
gynecologist, I'm gonna need to work a little bit better on that one. Um,
Oh, it's the sweetest though, especially,
yes,
when they understand the real terminology for it. And I will say,
yes,
you definitely have given me insight on the importance of that with our
yes,
children. And so our
correct.
boys know correct medical terms for all of
Yes,
the private parts. They know that
yes,
babies aren't in stomachs. Like
correct.
you have encouraged me to really break things down with them, which is
Yes,
super important.
yes, absolutely. So I do always encourage individuals to do that. I think it's sometimes being direct is much easier than people
Yes.
realize.
Absolutely. So, diving into prenatal care,
Yes.
what do you believe are the most important aspects of prenatal care?
I think the most important is, I mean, to start with, it's just getting prenatal care. I think sometimes people don't recognize the importance, especially if it's someone who sees themselves as being healthy.
Right.
I think that oftentimes what we forget is that even the healthiest person doesn't isn't necessarily not going to have a complication.
Mm,
And so you need to have prenatal care. You need to start early. You need to go regularly. You need to get those visits. You need to have those screening labs, those diagnostic tests. You need to have an ultrasound. And the
mm,
hopes is that absolutely you're a healthy individual and that your baby is healthy and that it is a low risk pregnancy, a low risk delivery. But if you don't go, if you don't follow up, if you don't have regular appointments, then you can miss those opportunities to diagnose potential complications and miss the opportunities to intervene,
right.
um, when we can.
Right. Absolutely. And I think when women start thinking through being pregnant and then trying to plan for delivery, in our minds, and I only say this after having 5 pregnancies, in our minds, we think our deliveries are going to go a certain way, and we want a
Yes.
certain thing. But that's not quite always the case. Every baby is so different. So walk us
Yes.
through how and why labors can be completely different from a previous one.
Well, and that's exactly right. From one to the next, you can't anticipate it's going to be exactly the same. And I think that's one of the biggest misconceptions. And it goes back to just because you're healthier, because you've had previously healthy pregnancy, doesn't eliminate the risk for potential complications, which is why you need to get prenatal care each and every pregnancy. You need to follow up with testing. And again, I love an easy, low risk patient who has no
Yeah.
medical complications. I mean, that's great for all of us.
Yeah.
But missing opportunities for early diagnosis and early intervention, increases so many complications for moms and babies. And if you look around and ask around, there are so many examples. I'm sure you know them amongst your friends and families where you have pregnancies where you've had several, and then all of a sudden one decides to throw you for a loop, and it happens.
Right. Absolutely. So, what are the most common types of complications during labor, and how do you manage them as a medical team?
Well, I mean, I think just statistically speaking, the most common complication would be an unplanned C-section.
Okay.
Right now we know that I think across the US and the numbers change a little bit year to year, but I think right now we're probably at 1 in 3 um, first time pregnant moms will end up with an unplanned C-section. And
Wow.
and the reasons for that are multifactorial. There's many reasons. Um, but again, that's 1 in 3 moms who is going to end up having a major surgery that they weren't expecting.
Right.
And so that's the statistically speaking largest complication numbers wise. Maybe not the largest from a a medical complication down the line, but there's all sorts of other complications, high blood pressure in pregnancy, high blood pressure in labor, postpartum high blood pressure. Oftentimes patients think that once the baby's out and we've done great, sometimes patients forget to follow up. And that's one of the reasons it's so important to keep your postpartum appointments and to touch base, because we have patients who develop high blood pressure after delivery. Bleeding complications in labor, infection. There's patients who have problems with the delivery, whether a traumatic delivery, lacerations and tears, and then also further complications postpartum. And so again, there's lots of potential complications where you want to make sure that you've got a provider and a team that you trust. And all of those things are so much easier to manage and sometimes anticipate, not always, but sometimes easier to anticipate when you've been getting regular care.
Absolutely. So when mothers come in and they have this elaborate birth plan and it doesn't go to plan, what advice or how do you walk them through the pivot of changing things?
Sure. Okay. And I think so. One thing, whenever somebody comes to talk to me about a birth plan, and this is just my preference,
Right.
and I encourage all women to talk to their providers. Is I personally, a lot of times I'll say, hey, do me a favor. I like to change the verbiage a little bit. I tend to call them birth preferences.
Okay.
And one of the reasons is I think, gosh, if I look back at where I was a year ago or 5 years ago, 10 years ago, think about your plans for life.
Yeah.
How many times could you have sat there and said, this is what I'm going to do for the next 10 years, 5 years, 1 year. And if you had written it down without any opportunity or any flexibility somewhere along the way, you're going to get disappointed.
Yes.
And so I say, let's make it a birth preferences and let's look at what your primary goal is. Because at the end of the day, what you want, what your provider wants, what your health team wants is for a healthy mom and healthy baby.
Yes.
And I think you have to keep that at the top of the list. And then you start to talk about what your other preferences are. And again, calling it a birth plan or whatever, that's just one of my personal things is I always call them birth preferences.
Makes
sense. And then again, I think the best birth plan or birth preferences is going to have flexibility, because what we know is that things can change quickly.
Right.
And that, oftentimes complications do change quickly. We don't necessarily get a lot of heads up sometimes. So the other thing you can do is you can think about, you can kind of not necessarily act out, but you can discuss a lot of what ifs before it happens.
Sure.
So, of course, if I have somebody, for example, who says, you know what, I'd like to have a vaginal delivery, but I'm going to want to use this for pain. Excellent. That's your preference. So number 2, if labor hurts, if you get to a point where that doesn't work for pain, what are some other modalities? And what do you know about them? And your support person, what are they going to do to help you? So let's come up with some other scenarios. So you want plans and preferences that have flexibility. Think about it more as a flow chart. You don't want to have this like unbroken tree. You want to be able to say, well, if this works, great. But if it doesn't, where are we going to go next? Because if not, if you don't have any ability to be flexible, to move, then you set yourself up for complications. And you just don't give room for reality.
Exactly.
The other thing I encourage individuals to do is to keep that open lines of communication with the provider. You never want to kind of hold inside all these wishes and desires and like at 38 weeks say, hi, I would like A through Z. Because that's not fair to anybody. It's not fair to your provider, but it's also not fair to you because you had all these things that you want and you didn't communicate it. And at the end of the day, I know I certainly do. I know most other providers, like they want you to have the outcome that you want. I mean, it's your delivery. And so the best thing you can do is to start early. Sometimes if you come in with a list of 20 things at one appointment, it's too much information for you and the provider. So do a little bit of a time, educate, a little bit at a time. Do classes. Another example that I tend to give patients and their support person, it's you would never sign up to run a marathon without maybe running a half marathon or at least like doing regular training intervals.
Exactly.
So, for example, if you're going to want to labor and labor without an epidural or IV medicine for pain control, well, then you need to have educated yourself or started working on some other techniques you can do for pain control. And that's just part of the process to help yourself. I mean, you've got to plan and prepare.
Exactly. I feel like you're in such an emotional state too
Yes.
while in labor that you also are not thinking quite clearly. And that is not the time to start thinking of plan Bs. Like,
Correct. Absolutely. Absolutely. And also, who's your support person? And sometimes it may be the father of the baby, but
mm,
sometimes I've seen dads who will very much upfront say, I'm not the one in that moment, or they get
right.
very overwhelmed. And
Yeah.
so, like, who is going to be there with you in that moment? Do you have a good support person? Because you're going to
Mhm.
need to have a good support person.
Absolutely. And I know high risk pregnancies are a thing these days. I mean, I'm sure they've been forever. But
Correct.
what are some factors that contribute to a high risk pregnancy and how do you handle those?
Yeah. And of course, the phrase high risk can
Right.
obviously mean a lot of different things.
Okay.
I mean, there's certain individuals who are going to just enter into pregnancy high risk. There's individuals who, are type 1 diabetics. They've been
Mm,
diabetic their entire life. They know that they are going to, when they conceive, enter in pregnancy with an increased potential for complications that others may not have. So there are those who start out high risk. There are those who may be healthy as can be, no medical complications, but then find out that they're pregnant with twins. Well, so that puts them in the category. So there's so many different things that may make somebody quote unquote high risk. And so it's a little hard to talk about all those at one time. Obviously, there's a specialty that deals with high risk pregnancies. Per se, the maternal fetal medicine specialists,
okay.
which we tend to call MFM,
Okay.
because saying maternal fetal medicine all the time is a little bit of a
A
tongue twister.
mouthful.
And oftentimes we'll refer patients if they have significant issues to an MFM. The other thing too is, you know, it may not be a maternal complications. Oftentimes on ultrasound, we may find a fetal complication that
Right.
needs the input from an MFM specialist. Um,
Okay.
Sometimes whether or not somebody gets referred may depend on where they're located, what region of the country. If you are located in a large urban center where there are multiple MFMs, it's very easy to send every patient that has diabetes or high blood pressure because they're located right there.
Sure.
If you're located in a little bit more of a rural area, it's just not as realistic to send patients who have chronic problems every week, 2 hours away from an appointment. And so you
Right.
may find that the local obstetricians tend to do a little bit more of the diabetes and hypertensive management.
Yes, that makes complete sense. So, do you
Mhm.
have any stories that you could share with us where maybe labor didn't go or even the pregnancy didn't go exactly how everybody planned, but there was success at the end?
I mean, sure, anytime mom and baby are healthy and happy, things go as planned.
Hmm.
And I think that's what, I have to hang my hat on at the end of the day.
Absolutely.
Um, I have had moms who very much have wanted to labor naturally, have been very healthy. I can think of somebody obviously in the back of my head and would never say anything as a HIPAA, but
Sure.
who very much, and I can remember she labored for so long, like
Mm,
unbelievably healthy, worked out. And oftentimes we talk about the three P's. We talk about the passenger,
okay.
power, and we talk about the pelvis. Well, the
Okay.
passenger is the baby. Um, so there are certain things you can manipulate with the baby. I mean, if the
Right.
baby's positionally isn't perfect, sometimes you can change positions in labor and maybe that baby will kind of change its position. But I mean, occasionally a mom will just grow a big baby. You know, you
Right.
can't get a 10-pound baby to come out of a 6-pound pelvis.
Yeah.
It's just sometimes not going to work.
Right.
Power. Power has to do with the uterine contractions, but
Okay.
sometimes it has to do with the ability of the mom to push. So moms that are exhausted oftentimes may have a harder time, or if a mom has an epidural, which is one of the reasons that oftentimes moms with epidural sometimes will push a little bit longer.
Okay.
And then again, the pelvis. There are just some women historically that are just built different. And
Right.
you've always heard the phrase birthing hips, but and honestly, you can't necessarily look at somebody. It's really not the hips, but there are just some women that are built to have bigger babies.
Yes.
And obviously in those components, there are parts of that that can be manipulated, and there are parts that just cannot, as much as
Sure.
you may want to will it all day long. And I have had some amazing, wonderful patients, and they could have wanted it all day long, and their healthy baby was going to come out by a cesarean delivery.
Okay.
Um, and I'm just because I'm just thinking of one in my head. And so when with her second pregnancy, she came in, and with her first appointment, she was like, "So we'll be scheduling my C-section." And
I
she
have
said,
big babies.
and I said, "Unless something is very different,
Yes.
absolutely."
Yes.
But anyway, so I can remember things like that. Yeah, I remember a lot of times where things don't go necessarily um as planned. But again, as long as mom and baby are happy and healthy,
Yes.
to me, it's always a great day.
Absolutely. Speaking of great big babies, I should say. I mean, listen, I don't know if our listeners out there have ever had babies over 10 pounds, but my Ezra was 11 pounds and 4 ounces. And I
Yes.
just beam with pride when I tell people that
Uh-huh.
because he was a big
Yes.
boy.
Yes.
After giving birth to him, and he was cesarean, like you said, I cannot even
Yes.
imagine. I cannot even
No.
imagine birthing a child that big.
Correct.
People would come into the room and they would be like, "Where is that big baby?" They just wanted to see the
To see it.
chunky
Yes. Yes.
baby.
Yes.
And I mean, that was just a complete change because it's really hard to tell sometimes how big they are when
Mm-hmm.
they're, inside. And I remember not even having clothes that would fit him. Like he was bigger than all the clothes that we
Oh, yes.
brought to the
Yes.
hospital.
The poor little newborn diapers were
Yes.
giving him Dunlap. Yeah.
They were like trying to find him size
Yes.
one diapers. He
Yeah.
just,
No.
you
No.
can never tell. And none of my other babies were ever that big. It's just so different from
Mm-hmm.
pregnancy to pregnancy.
Yeah. And you don't necessarily do anything different.
No, I mean, I wasn't diabetic. There was nothing that was
No.
different from each pregnancy. He just was a large baby boy.
Yes. Mm-hmm.
So, how can you educate and empower your patients to make informed decisions about their care?
And so, I mean, again, I think patients that come to appointments and ask questions are more likely to get involved
Okay.
and educate themselves.
Yep.
Um, and, childbirth classes, there are
Childbirth.
good resources available to
Yes.
read and then come in and ask questions
Mhm.
as they start to get closer to the labor process. What are some things that you want and don't want? Do you
Right.
have preferences? What might they be? So a lot of it is just trying to fill out where someone is.
Right. And do you kind of get the same common questions, especially from first time moms?
Yeah, I think a lot of moms are nervous and scared about C-sections.
Okay.
And that's so understandable. That's so
Right.
understandable. I think that moms are afraid of these super long labors because we've all know stories that that first stage of labor can be very, very long for some women, and historically it's a little difficult to change that because that's just
Right.
physiologically the way it is. Um, but we all know someone who has this story of these 24, 48-hour labors, and people come in and they're like, I don't want that. I don't want what
Right.
they told me they had.
How do I not do that?
Or someone they know that had a bad tear or laceration. And so I do have a lot of patients who will ask me about those things.
Okay. And what advice do you give? Is there any advice you can give to help a woman not tear during labor?
Um uh, it is difficult because there's a lot of opinions on this right now.
Okay.
I think
Okay.
that what data has shown is that the best thing is to control the head at time of
Okay.
delivery. I will say from a provider standpoint, we
Mhm.
now do recognize that the practice of episiotomies is something that has very much gone out of fashion.
Okay.
Though for years it was kind of a typical trend. But
Right.
if you ask most providers now, they will tell you that episiotomies are something that are certainly not taught in residency programs, or certainly
Okay.
things that are not performed. And I encourage patients, ask your provider, do
Yes.
they cut episiotomies? When would they cut an episiotomy?
Okay.
Because there have been very good studies that have shown that if you have an episiotomy, it's
Right.
more likely
Right.
to progress to a third or fourth degree. Um,
Okay.
that being said, I think that there are occasions where you have a large baby,
Mhm.
and or if you get into a complication and you need to expedite a delivery
Sure.
because of fetal distress or
Mhm.
trouble, you may end up having to manage parts of that delivery where a complication may occur. And again, those aren't common, but
Right.
certainly nationally, we do see a lot less third and fourth degrees now
Okay.
than we did 10 years ago, certainly a lot less than we did 20 years ago. And a lot of that is because providers aren't performing episiotomies.
Okay, that's good to know. And for all of our listeners who don't quite understand what an episiotomy is, can you give them a quick definition?
So, an episiotomy would be making an incision to help provide room for delivery. So, traditionally, the thought was it was kind of, if someone was going to tear, that it was better to just kind of provide a clean, straight incision,
Mm,
that it would be therefore easier to repair and easier to heal. And so, for probably decades, that was kind of the routine practice.
okay.
And honestly, not even uncommon until just a couple years ago. I would even have patients come in and say, "Well, if I look like I'm going to tear, could you just perform an episiotomy or cut me?" And I would have to kind of educate. And then what
Mm,
data showed is that once you made that incision, it's kind of like providing a path of least resistance.
right.
And that women who had episiotomies, again, were more likely to have continued into a third or fourth degree, which is just a deeper tear.
Okay.
And that women that had episiotomies were more likely to have problems with healing, more likely to have long-term complications as far as pain with their scar,
Okay.
whether it be painful intercourse afterwards, whether it be problems with bladder and bowel.
Right.
But anyway, incision complications. And
Okay.
so, as the trend of cutting episiotomies has just drastically gone down, we just don't see as many third and fourth degrees.
Okay.
Or if a woman does have a third or fourth degree, it's much more likely not because an episiotomy was performed. It's much more likely to be the result of kind of a natural third or fourth degree, if that makes sense, which
Sure.
still data says should heal better
Okay.
than if it was caused from an episiotomy.
That makes sense. So, switching gears from a vaginal delivery to a cesarean, what would a woman, I don't know, just experience? Like, what is it like to have a cesarean? And how can they prep for that mentally?
Um, well, I think one thing that people don't appreciate is that it is major surgery.
Right.
It is major surgery. And what other major surgery out there do people have when you're awake and then
Right.
say, okay, now I need you to change the baby's diaper. I know
Yeah.
you had major surgery 12 hours ago. Like there's an incision hip to hip
Wow.
and you're awake and you didn't get any downtime. Oh, and if you're going to breastfeed, like
Yeah.
right in the recovery room, we wanted to make sure you got that skin to skin and get that
Right.
baby latched on. And we've got your catheter out at 6 hours so you can be up moving because we don't want you to get a blood clot. I
Right.
mean, did I say it was major surgery?
It is a lot.
It is intense. So I will say in response to that, and I haven't had a cesarean delivery, but obviously I've taken care of patients who've had cesareans, whether because I performed their cesarean and taken care of, or I've taken care of gynecological patients who have operated on. And I will tell you that when I have patients down the road that I'm operating on, man, I'll take patients who've had cesarean
Yeah.
deliveries any day because they don't complain of pain.
It's so true.
It's like they have this perspective of pain
Yeah.
they never complain, they never hurt. And so I
Mm.
have this massive respect for patients that have to have cesareans.
Yes, it's a totally different ball game. I mean,
Yeah.
I've had 5, but I've never delivered vaginally. So I always felt like, man, I wish I could have had one vaginally. It wasn't in the
Mhm.
cards for me. But to be completely honest, people are always shocked when they hear I had 5, but that's all I knew.
That's all
It's
you know.
all I'm
Yeah.
used to is that's just the recovery after having a baby, you know?
Right.
And
Yeah.
so when you have friends who started out with a vaginal birth and then they had the cesarean for the second one, their worlds are kind of rocked because
Yes.
it is a completely different recovery than they've been used to. And
Yes.
you're right, the world kind of puts a lot of pressure on you right after having that major surgery to just snap into motherhood and get up, get
Yeah. I
going,
mean, it
you
was just a
know.
baby. Everybody has one,
Right.
right? So I don't, yeah.
It
Yeah.
is
We
so
forget the fact
wild.
that everything, like we cut through everything.
I mean, and it's a lot of layers, isn't it? How many layers do you I saw a video one time and it blew my mind because I just didn't fully comprehend how many layers y'all cut through to get to the baby.
Yeah. I mean, we like pull your rectus muscles
It's
aside. Yeah.
wild.
Yeah.
I'll
We
never
may,
forget.
yeah.
One time I asked my husband, I was like, "Babe, something is burning in here." And he's like, "It's fine. Don't worry about it." I'm like, "No, something's on fire." And he's
Mhm.
like, "No, it's fine." I'm like, "What is it?" And he's like, it's your skin. Like they're cutting you
They're just
open."
cauterizing some stuff. It's
They're
okay.
cauterizing and that's what you're smelling, but you're totally, unaware
Yeah.
of everything that's going on because you can't feel anything.
Yes.
It is
Yeah,
so
it's
wild.
major. Yeah, and on the flip side, for women who are candidates and who are able to VBAC or have a vaginal birth after a
Right.
cesarean, oftentimes if I see them the following day after delivery, they're like, "Oh my gosh, this this is much better."
Yeah.
Like, I mean, my butt kinda hurts, but,
Right.
like, none of this other stuff, like, this is fabulous.
Yes. Oh my word. It is just 2 totally different set of cards you get handed, and you figure it out as you go through it. You really do. I mean,
Yes.
I have a soft spot in my heart for C-section mamas, especially when they've only experienced a vaginal birth, and so I feel like my phone always blows up with a, "How do I do this? How do I prep?" And I think my biggest saving grace was that darn girdle, the belt that just after your surgery, it just kept it all in nice and
Yes.
tight.
'Cause you don't want anything to move. You don't want
Yes.
anything to move. Because if you cough or sneeze or step
Yes.
too yes. Mhm.
So, what would you say is the most rewarding part about your job? Like, do you have any
Uh,
memorable experiences that you
oh,
think
I mean, I have lots. I mean,
this
I
is
can
it?
still remember, I mean, some of the couples that were in my residency clinic that
Oh,
I just loved so much, and I can remember the first couple that brought me cookies when I was a resident. I was like the sweet and I can remember what they named their baby.
oh,
Um but I mean, and then so through the years, I mean, every delivery, I mean, it truly is miraculous and it's an
yes,
amazing experience because it's childbirth and you're
yes,
a part of these people's lives.
yeah.
Just to be allowed in that is so unbelievable. But then, I mean, I've had patients who have experienced such unbelievable loss and have a perseverance that I personally can't imagine.
Mm,
Who've had infertility or loss, and then to see them come out the other side
right.
is sometimes just like gut wrenchingly emotional and amazing. And then I've had patients who've come back and have gone through successful adoptions as well
Right.
to have their child.
Mm,
But also because I see patients back for GYN, I still get to see their families grow.
yes.
So there's so many stories
Oh
that
my gosh.
I mean I could list for days.
Yes. And you're so right when you say you kind of become, I don't know, a piece of their family in a way because
Hmm.
giving birth is just such a personal moment. And I will never forget. I mean, I became friends with almost all my nurses because I was just beyond grateful for the kindness and the medical care and helping me get through a time that is scary, very scary.
Yes.
But also you don't really know how to navigate it, especially the first, few babies. You don't know what to do with these tiny little humans.
Mhm.
And then so everybody from your OB to the nurses to the, postpartum team, they play
Mhm.
such a special part in your delivery. They all still get Christmas cards from me, by the way.
Yes.
We still send them out to all of them because they're forever a piece of our story.
Oh, yeah. I have a massive stack every year,
Yeah.
and I keep all of them on,
Yeah.
like, those big silver, like, rings. I have rings
Right.
and rings and rings, and love, like, my Christmas cards and my baby pictures and truly cherish them.
That is really awesome. So, my last question to you would be, a lot of our listeners have experienced an unplanned pregnancy, or may be going through one right now. So, I always love to give them a glimmer of hope and something to hold on to at the end of our episodes. And so, my question to you would be, what advice would you have for a young, scared, she could be a college student or maybe just a young mama who just found out she's pregnant? What would you say to her?
And so I would say, oh my gosh, you're certainly not alone.
Mhm.
And I think that thankfully we have baby steps that shows us that. But I hope you can find a provider in your area that will second and third that as well. Because I think if you go into your medical office, you will also find that even from sitting in the waiting room, you're not alone.
Right.
Um, but I just urge you to find a provider that you connect with and can talk with. If at any time you need further support, please ask
Mm,
and reach out, because what you'll find is there's so many resources.
yeah.
Obviously, there's avenues such as baby steps, but providers should also be able to provide you with community resources.
Mm,
And the other thing too is childbirth classes.
right.
You know, f- Connect with other individuals that are pregnant.
Mm,
Find your network, find your support, because I think individuals have a tendency to feel like they're the only one, and what you'll find is that you're not, and there's so many others that are truly willing to share and want to be connected.
absolutely. That is a beautiful piece of advice. And thank you so much for taking the time to answer all of our questions. I really hope we were able to, give our listeners an inside look behind the curtain scene, of what this looks like for childbirth, prenatal care, postnatal care, just all the things. So thank you so much for taking the time to join us on the podcast today.
Oh, thank you for having me on.
Yes. And to all of our listeners, we hope to have you back on our next episode of Unplanned and Untold. Bye bye. We hope you enjoyed that episode, as we are committed to bringing you the real, raw stories of those who have defied the odds and achieved their goals. But we're not stopping there. We are dedicated to improving our podcast quality so that we can reach an even wider audience. If you believe in the power of these untold narratives, consider donating or sponsoring this podcast by visiting unplannedanduntold.com.